Hello everyone. Today we're going to have a walkthrough uh, across this Guideline Essentials clinical series slides from the American Heart Association that is uh, on the prevention, detection, and evaluation and management of high blood pressure in adults, which is a very important topic because of, first of all, the prevalence of high blood pressure, especially in northern African countries, and especially in Algeria, and the comorbidities associated with it in terms of complications and multi-organ system damage that it causes. So we're going to have a pretty quick review of these slides. Um, the reason I prefer this, the American Heart Association's recommendations over the European ones, is the population profile. So the European population tends to be an aging population that has quite a different set of characteristics clinically than the Northern African population, which is, I think, this is my own opinion. I'm not an expert or anything, but I think it's similar to the Americans, where they have a high prevalence of other cardiovascular disease like diabetes, type 2 diabetes, and obesity, and yeah. So I think the recommendations fit us more than the European ones. So starting with this rather simple slide, which talks about the classes of recommendations, which represent the strength of a particular recommendation and the level, quality of evidence that supports the underlying recommendation. So for class one, we have strong evidence that the benefit outweighs the risk, and which means that if a particular set of instructions is class one, it means that we strongly advise, it's rather strongly advised by um, the, the, the existing evidence which supports the use of that particular set of instruction, whether it's a therapeutic intervention or a behavioral one, a dietary change, or um, other things. So a level one evidence which can support any of the different classes, including class three, which means that a particular uh, intervention is harmful, that the risk outweighs the benefit, and that it should not be indicated. So levels are independent of classes. So level A, we have high quality evidence from more than one randomized controlled trial, or meta-analyses of high quality randomized controlled trials, or one or more RCTs corroborated by high quality registry studies. So these are the three criteria that make a particular set of evidence a level one or level A. Level B, BR, we have BR and BNR. So R stands for randomized, which kind of increases the quality of the evidence because you have less statistical bias. So for level BR, we have moderate quality evidence from one or more randomized controlled trials. And the moderate quality here depends on many things. It could be a small size study, it could be that we have a restricted population. Maybe there's a selection bias here and there, but it's randomized, so it's level BR. A meta-analysis of moderate quality RCTs, which is the same thing pretty much. Level B NR, it's non-randomized moderate quality evidence, which has to be well designed, well executed, but nonetheless non-randomized. And that engulfs both observational studies and registry studies, and meta-analyses of such studies. Level C, LD, which means limited data, engulfs randomized or non-randomized observational or registry studies, with limitations of design and execution. So the difference between level B and R is that level B and R quality has to be like well designed, well executed, with some kind of hiccups, let's say, here and there, with how the overall study was executed. Level CEO is basically expert opinion, which is what the EO means, which is well respected, but it's not up there in the evidence quality hierarchy. Going back to the classes of recommendations, we've talked about class one, which is strong evidence that the benefit outweighs the risk. And remember, each class can have either one of these levels of quality of evidence. Class 2A is moderate strength. So we have proof that the benefit outweighs the risk. So the treatment or the particular therapeutic intervention is reasonable. It can be useful, effective, depending on the cases. And we have to outweigh the risk. We have to basically resort to risk-benefit ratios and and introduce the treatment when necessary. Class 2B, we have weak strength, that the benefit either exceeds or equals the risk. So it can be useful in certain cases, which means it might be reasonable to consider it in certain patients. So the usefulness, effectiveness is unknown, unclear, or uncertain, or not well established, or is variable from one person to another, one population profile to another. Class 3 is basically the opposite of class 1, so we have no benefit. And so the benefit either equals the risk, or basically the risk supersedes the benefit in certain populations. And it's not recommended, it's not indicated. And class 3 is kind of useful because in medicine we say we do no harm, and I think we should start with class 3. So in not we're going to talk about hypertension today, but in every particular medical scenario, when you think about introducing a medical therapy or any kind of intervention, non-invasive, invasive, anything, if it's class 3, just stop. You have to just literally stop and don't do it. So let's go back to the basics. We have definition and classification of blood pressure, a normal blood pressure or an optimal blood pressure. These, I should emphasize, is the definition according to the American Heart Association. So less than 120 millimeters of mercury and less than 80 millimeters of mercury for the systolic blood pressure, and diastolic one respectively is a normal blood pressure, an ideal one. An elevated blood pressure, it doesn't necessarily mean that we have hypertension, but it's elevated. It's like pre-diabetes and diabetes. So 120 to 129 millimeters of mercury for systolic blood pressure is called elevated blood pressure. These are patients at risk of developing hypertension and should be surveilled. And some percentage of these patients are stage 1, but they have a hidden hypertension, which is kind of the inverse of what happens in white coat syndrome. And we have to have like a diastolic blood pressure of less than 80 millimeters of mercury, with a systolic between 120 and 129. So this category here is very important because we can have people who just are stressed and have this high surge of catecholamines, and we could also have a high percentage of patients who already are in stage 1 or even stage 2 hypertension that is masked and doesn't show up. So according to the AHA, again, stage 1 hypertension is defined by a systolic blood pressure superior to 130, but less than 140, so between 130 and 139 millimeters of mercury, or a diastolic one between 80 and 89 millimeters of mercury. This radically differs from the European, how the Europeans define stage 1, which starts at 140. Stage 2 hypertension is a systolic of 140 equals or superior to 140 millimeters of mercury, or superior or equals to 90 millimeters of mercury for the diastolic one. And we could have either one. So if you have a patient with a systolic blood pressure of 120 and a diastolic one of 95 millimeters of mercury, they already are in stage 2 diastolic hypertension, according to the HAA. Again, I emphasize on this. So we have a class 1 recommendation. In adults, blood pressure should be categorized as normal, elevated, or stage 1, stage 2 hypertension to prevent and treat high blood pressure. This is pretty straightforward. So we're going to talk about the best practices for accurate in-office blood pressure measurement. This is highly theoretical and doesn't always apply in, especially in kind of emergencies and but these are best practices and they should be considered. So we have to avoid caffeine, exercise, or smoking for at least 30 minutes before measuring blood pressure. This is particularly useful to give to your patient when you ask them to measure the blood pressure at home. The patient's arm should be supported at heart level to basically delete that difference in height, and because we have gravity, and if the arm is elevated or not at the same level as the heart, we're going to have differences in basically the gravitational pull on the blood mass inside our vessels, and that's gonna slightly make our measurements inaccurate. So patients aren't at heart level. The patient could be standing on a chair, or they could be laying on their backside. The patient should be relaxed, with flat feet, legs uncrossed. I'm sorry, and with their back supported by anything for at least 5 minutes. So that's pretty straightforward. No need to explain anything there. One important point is that the patient and the clinician should not talk during the rest of the measurement, and there should be no use of phones. We have to use, of course, a blood pressure measuring device that is validated for accuracy, and we have this link here to test the different companies that make these devices. So validatebp.org will give you a list of companies that have been or have had their devices tested, because we could have like manufacturing issues, especially with Chinese companies and some of the let's say underground companies that make cheaper devices that are not as accurate as the validated ones. We have to use the correct cuff size on bare arm, so for obese patients, for basically kids. There's a particular this is very underrated to talk about, but I'm going to talk about it anyway in this part. So for kids, we have not only we must not only use a smaller size cuff, but we have to use the standard kind of diagrams to compare blood pressure values, because you could have high or lower blood pressure values in kids, and you have to like with their height and uh, basically we have to compare to the standard statistical average of the population of kids. This is for blood pressure. Blood pressure also should be done in a temperature controlled room, because excessive heat can cause vasodilatation, excessive cold can cause the inverse of that, and we could have hormonal interference with the measurements. So recommendations, class 1, when diagnosing and managing high BP in adults, standardized methods are recommended for accurate measurements and documentation in office BP. Class 2A, which, as you might have recall, let's go back here. Class 2A is, well, something that has moderate strength when it comes to benefit versus risk. Uh, when measuring in-office BP in adults, it is reasonable to use an oscillometric method with an automated device over an oscillatory method. This is also something that's new, but it's still class 2A, not that strong, not that strong of an evidence, but it's still strong. Auscultation is not as accurate, it turns out, as automatic devices, especially as they get more accurate. They get more sophisticated with more interesting algorithms. Um, so automation is preferred, especially when it's available. At least that's what the Americans say. So essential laboratory tests and diagnostic procedures. When hypertension is suspected or confirmed, laboratory and diagnostic procedures are a standard part of the evaluation. So we don't just measure the blood pressure and call it a day. We have to continue with laboratory tests, especially when we look for complications and all that. So this information is really critical because it provides a baseline. So hypertension, as you know, is a chronic illness. It's a chronic problem, and when we diagnose it, we need a baseline in terms of renal function, cardiac function. So we have to do the additional tests to surveil our patient and monitor the evolution, whether it's positive or negative, and it will help us decide which treatments to put forward and which treatments to adjust as time goes on. So management decisions need a baseline that we need to establish with these diagnostic laboratory tests when we diagnose blood pressure. And it's a class 1 recommendation. And we should repeat these tests annually, at least, to monitor potential adverse effects of therapies, including kidney disease progression and changes in predicted cardiovascular risk. This is very important. So what we care about mainly in hypertension, which is a cardiovascular risk, independent cardiovascular risk factor, is the cardiovascular risk. And there are many scores to estimate the 10-year risk of developing or having cardiovascular events, major adverse cardiovascular incidents, or MACE in short. Well, we should consider additional diagnostic evaluation tests in suspected secondary hypertension. And we're going to talk about the different scenarios and different, different indicators that would push us towards looking for secondary hypertension that we should look for. I think it's probably 5% of the total amount of hypertension, and we can consider that hypertension is a very highly prevalent pathology. It's not a negligible percentage to look for secondary hypertension, especially because it's treated. It's radically treated when we eradicate the etiology. Hopefully, it's something that we could fix. So yeah, we're going to talk about the different things that would push us. So please look for secondary hypertension. And that includes not only a very well done clinical exam, but we should always keep in our heads that secondary hypertension exists. We must look for it, and we must test for it before we start a treatment like complete idiots. And we assume it's primary hypertension, and we let the patient continue evolving, because usually secondary hypertension does not respond well to treatment, even with multiple antihypertensive drugs. So routine diagnostic studies, we should do complete blood counts, so serum sodium, potassium, and calcium, serum creatinine with an estimation of the glomerular filtration rate, or GFR. Different method, different, I don't care what method. Uh, I don't think they do care which method we should use, but I think the Cochrane method does not work well, does not estimate GFR well in extreme age and extreme weight. So we should avoid it. Personally, my favorite is the MDRD or the CKD EPI formulas. Interesting point here. Serum calcium, I don't think it's recommended by the Europeans, but I think we should look for it. It's not as well in secondary or primary hyperparathyroidism. We should test. We should actually look um, for it with serum calcium, which of course should be corrected with either albumin or total protein. We should do a lipid profile, which enters in this general predicted cardiovascular risk stuff. We should look for fasting blood glucose or hemoglobin A1C, again, cardiovascular risk. We should do thyroid stimulating hormone tests because we can have hypertension secondary to hyperthyroidism or even hypo, I think, in some scenarios. We should do a urine analysis to look for protein and all that. That's hypertensive nephropathy, urine albumin, to creatinine ratio, which is becoming a standard. Urine protein to creatinine ratio is also recommended. And we have to do an EKG with 12 lead. Yeah, and this is recommendation class 1. So we should do these things. Notice the absence of an echocardiogram, which is not systematic, unless there is an indication. So from clinic to home, how to measure or monitor blood pressure. So class 1 recommendation in adults with suspected hypertension, out of office BP measurements by either ABPM or HBPM. Well, of course, there's a funny acronym here. This is not an anticoagulant therapy, which is what the French abbreviation of HBPM means. I don't know. So ambulatory blood pressure monitoring or home blood pressure monitoring, which are class 1 recommendation to confirm diagnosis of hypertension. We should always use either one of these methods, or we should not base our diagnosis on a single in-office measurement, because we can have white coat, hidden hypertension, or simply an unreliable reading in office. Again, class 1 recommendation in adults who are taking antihypertensive medication. Home blood pressure monitoring is recommended for monitoring the titration of BP lowering medication. So when we start our treatment, we should continue, or should advise the patient. The patient must simply continue to measure their blood pressure so we can titrate the dose. Usually we start with lower doses and we titrate up, and our reference for that is the home blood pressure monitoring numbers. Yeah, we can do stuff like telehealth, which is very underrated. We don't do much of it. We barely escape the nightmarish paperwork in this country. So I don't know. Not something very important, but it should be done, should be considered. So class 3, we have a class 3 no benefits, absolutely must avoid, not do things. In adults, the use of cuffless BP devices is not recommended for the diagnosis and management of high BP. Cuffless BP devices include smartwatches and other crappy Chinese technology BS. We should not use that. So we should use the classic stuff, and we must use a cuff, either automated or oscillatory if not available. So we have a table here, which I'm going to put the link to this slide series, and everyone can look at these numbers, which compares the equivalence between in-office versus home, daytime, nighttime, 24-hour ambulatory blood pressure measuring readings, and their significance. So, for example, here in office, 160 over 100 blood pressure values correspond to a home blood pressure measuring numbers of 145 over 90. I'm not going to go over these numbers. This is simply a reference table that everyone can look up. So, talking about briefly about the causes of hypertension from lifestyle to genetics, we have dietary intake factors. A higher sodium intake is a highly incriminated factor. Genetic variants for non-dietary factors. So these include mutations in sodium channels, sodium problems, multi-receptor mutations, or a series of receptors implicated in excreting sodium, and of course high dietary intake of sodium, especially chronically. Low potassium intake, which is interesting, has been linked to primary hypertension, low calcium, and low magnesium intake. So we must highlight low magnesium intake, which is really underlooked. I think it's very underlooked. So a prime example of this is a preeclampsia and eclampsia. The reason we give magnesium is because it lowers blood pressure in those patients, and well, low magnesium intake can be a contributing factor, if not a cause of hypertension. A low diet quality, low intake of fruits, vegetables, plants, protein, and fiber. So our modern crappy diets are also implicated not only in atherosclerosis in general, but specifically for hypertension. Alcohol intake as well can raise blood pressure values, and it's advised to I don't know. Well, I don't think this applies in our country because, well, we do have a a rising rate of alcoholism, but we don't have any kind of special counseling programs for alcoholics. So alcohol reduction and cessation is highly recommended. Non-dietary factors include genetic variants, which there's not much we can do about it. Obesity and overweight, there's a lot we can do. Changing the diet, exercise can help lower um, blood pressure values in these patients. Sedentary lifestyle with low physical activity and fitness is also a factor, and the pathophysiology is very complex. Sleep disturbances related to quality, duration, disordered breathing. In this entity, we must screen for secondary hypertension under sleep apnea, especially in obese patients. Some obese patients can have like intermittent high blood pressure values due to them being literally strangulated at night, but they are by their own weight, and it's not in their interest to just give them medication, which does not help practically that much, because their problem is inherently in the activation of their sympathetic nervous system when I don't know, the throat collapses during sleep apnea episodes. We should do a polysomnograph and treat with CPAP if necessary. Psychosocial stressors, very important factor. It could be a cause, it could be an aggravating factor, so we should refer these patients to proper counseling psychiatrists. And this is very important in this country, in our country. Many people have psychosocial stress. Air pollution is also implicated. Again, the mechanism is hypoxia and hyperactivation of the sympathetic nervous system. So we talk about white coat and masked hypertension, which is two entities. If you remember, we talked about in this category of elevated blood pressure, and both also stage 1 hypertension. We can have patients with white coat effect or syndrome in this class who are not uh, people with hypertension, but nonetheless they're at the same risk level as people with hypertension. So white coat hypertension is BP, blood pressure values high in office and normal or elevated outside the office setting. And again, this is where the interest of measuring blood pressure at home comes, um, which helps us define what a white coat hypertension or effect is. Masked hypertension is the inverse of that, is high BP outside of the office setting and normal or elevated in the office setting. Ambulatory blood pressure measurement is preferred for excluding white coat and masked hypertension among individuals not taking antihypertensives. Adults with in-office BP superior or equal to 160 over 100 should be promptly started on antihypertensives. This, again, is the American Heart Association recommendations. For the Europeans, I think, if I'm not mistaken, it's grade 3, which starts at 180 for systolic and 110 for the diastolic values. Studies have shown that individuals with white coat and masked hypertension compared to those with sustained normal tension are more likely to have sustained hypertension on follow-up. So these, again, are high-risk patients for becoming, for having sustained hypertension, and they basically have the same risk profile. So even if we don't start them on antihypertensives, we should do a regular follow-ups for these patients because they are at high risk of becoming patients with hypertension. So class 2A recommendations in adults with untreated office systolic blood pressure superior or equal to 30, which again defines grade 1 hypertension, or diastolic of superior or equal to 80, and without office systolic blood pressure superior to 160 or diastolic superior to 100, which is where we should start treatment, it is reasonable to exclude white coat hypertension using out-of-office BP monitoring before a diagnosis of hypertension is made. So we have a time. We have time. We must not just rush ourselves to a diagnosis. We should take our time and establish a correct diagnosis. In adults, again, 2A class recommendation, reasonably strong evidence. In adults with white coat hypertension, out of office BP monitoring is reasonable to exclude transition to a diagnosis of sustained hypertension. Again, in that gray area of people with elevated numbers, we should always go slowly and establish a correct diagnosis. In adults with apparent treatment-resistant hypertension on office BP, so these people are people with an established diagnosis that resist treatment, it is reasonable to exclude white coat effect, which is a form of pseudo-resistance, using out-of-office BP monitoring. So when we start patients on antihypertensive therapy and we follow their, blood pressure values in office, and we find that they seem not to be responding on treatment, before we increase doses or change classes or introduce associations, we should always look for pseudo-resistance with this in-home versus in-home or out-of-office BP monitoring. Again, class 2A recommendation. In adults who are taking antihypertensive medication and have elevated office BP, systolic, again, 130, one superior or equals to 130 for systolic, and a diastolic superior or equals to 80, but do not have resistant hypertension or office systolic blood pressure superior to 160 or diastolic superior or equal to 100, it is reasonable to exclude white coat effect using out-of-office BP monitoring. So again, always look for this white coat effect in masked hypertension. Jumping to class 2B recommendations, again, a little bit less reliable, less strength, when it comes to evidence, in adults with untreated office systolic blood pressure less than 130 and a diastolic less than 80, so these people have maybe elevated blood pressure values, it may be reasonable to exclude masked hypertension using out-of-office BP monitoring. Again, to be a recommendation, to be class recommendation in adults who are taking antihypertensive medication and have office systolic blood pressure less than 130 and a diastolic less than 80. So these people are, again, in the objectives. It may be reasonable to exclude mass uncontrolled hypertension using out-of-office BP monitoring. So always do not take, what I understand from these recommendations is do not take in-office measurements as a reference, as the only reference. Always keep the patient implicated in their own pathology by basically asking them to keep measuring their blood pressure values. So secondary forms of hypertension. This is an interesting one. When to look for secondary hypertension. If the patient has any of the following criteria, we must look. Okay. Again, 5% of people with hypertension have secondary hypertension, and we should not, absolutely should not misdiagnose this as primary hypertension. So drug-resistant induced hypertension, corticosteroids, I don't know, excessive thyroid hormones, certain medication used, especially in winter season for the flu, which were nasal decongestants, which work by the bias of vasoconstriction, like blood vessels. If people are like we basically we should look for what the patient is taking and look if those medications can cause secondary hypertension. If yes, we discuss with the medical professional who installed those treatments, and we either can switch the patient or reduce their dosage. Again, an exacerbation of previously controlled hypertension is also a factor. If the patient is well controlled, of course, it doesn't mean it's secondary, but we should look for exacerbating factors, either non-adherence to treatment, diet issues, and again, we should keep it in our heads that there might be a secondary hypertension that is making our patient have uncontrolled blood pressure values. Disproportionate target organ damage is also a factor that must prompt us to look for secondary hypertension. So if you have maybe someone who's 45 who has been diagnosed a year ago and has really severe organ damage, it could be kidneys, it could be eyes, it could be, I don't know, the heart, it could be anything, we should look for secondary hypertension. Accelerated or malignant hypertension, also, again, relatively rare, especially, well, even in emergencies or pseudo-emergencies, but we should look for secondary hypertension if the patient does an episode of malignant hypertension or accelerated hypertension. An onset of diastolic hypertension in older adults in ages superior to 65. This is a very, I think, misknown entity. So diastolic blood pressure values are often overlooked. If someone is superior to 65 and they have an onset of isolated diastolic hypertension, we should look for secondary hypertension as well. Unprovoked or excessive hypokalemia. This is a classic, which is why we should check for sodium and calcium and potassium levels. If you have hypokalemia, it could be secondary to primary or secondary hyperaldosteronism. Insomnia or daytime sleepiness, which both are associated with sleep apnea and other sleep disorders. that could potentially be cured, essentially with CPAP, which is continuous pressure airway, blah blah blah. You know the drill. Concomitant adrenal nodule. Maybe it's an incidentaloma that was discovered on an abdominal scan for abdominal issues or something. It could prompt us to look for secondary hypertension, which could be the cause. This could be a pheochromocytoma, or I don't know, a cortisol secreting tumor, or else a history of early onset stroke. If someone is 35 and they have ischemic hemorrhagic stroke, that's probably secondary hypertension, so we should screen for it. If any of these factors, if only one of them exists, we should look for it, depending on the context. Okay. Um, if the if you have a positive screening test, yes, we should refer the clinician to a specific secondary HCN expertise. If the patient, for example, have primary aldosteronism, they go to endocrinology. If they have sleep disorders, they should go see a sleeping specialist, or I don't know, a pneumologist. If they have, I don't know, excessive unprovoked hypokalemia, again, endocrinology, etc. If no, well, screening is not indicated and we should stop. These are both class 1 recommendations. A class 2 recommendation here is in adults who have a positive screening test for a form of secondary hypertension, referral to a clinician who has expertise in that form of hypertension is reasonable for diagnosis, confirmation, and treatment. So, how do we manage blood pressure, which is, I think, the bread and butter of this slide series. So, the Americans, what I like about the Americans is that they take on the patient as a whole. They don't just drill the patient with medication, or of course they do, but they consider lifestyle and psychosocial approaches as well. So for weight, if you have an overweight or obese patient, class 1 recommendation, we have to target a 5% or more weight loss compared to baseline. And we have that each 1 kilogram of weight that the patient drops is associated with a drop in 1 millimeter of diastolic and systolic blood pressure values. So 10 kilos is, well, 10 millimeters of mercury in both, which is interesting. It's not that negligible drop. So if somebody has diastolic blood pressure isolated, a 10 kilo drop could easily make them not hypertensive. So when it comes to diet, with or without hypertension, it is both advised to eat healthy. So DASH, heart healthy eating pattern, I don't know, Mediterranean diet rich in fruits, vegetables, nuts, avoiding, the stuff. This is not a TV commercial. I'm not gonna go through the classic stuff. Anyone can look the healthy diets up. So class 1 indication, reducing sodium intake to less than 2.3 grams per day, ideally less than 1.5 grams per day. Notice this is just a reduction, not complete deletion. It's very annoying when, I don't know, studies come up with these numbers, 2.3 grams. What does that mean? What does that mean for the patient? I mean, should they weigh how much sodium they take daily? I don't know, but it is advised generally to tell patients to take less sodium, and especially to look up for hidden sources of sodium, like cheese, for example. Class 2A, salt substitutes, which are potassium based. I don't know if these are available in this country. I think they are, but it's a class 2 recommendations to substitute these. The classical sodium chloride with potassium chloride. Especially, of course, we have to look if the patient has other causes for hyperkalemia, and if yes, we should not give them potassium substituted salts. Class 1, a moderate dietary potassium intake. So we have to kind of moderately increase potassium levels. Again, if you remember, hypokalemia is implicated in the pathophysiology of hypertension, as well as hypomagnesemia. We should correct both of those. So when it comes to alcohol, again, with or without hypertension, this is just a general class 1 alcohol recommendation. Class 1 recommendation, alcohol abstinence if possible, or taking less drinks, less or equal to 1 drink for females per day, less or equal to 2 drinks per day for males. Exercise and stress, again, with or without hypertension, we should basically manage stress. This is class 2B, stress reduction, meditation, yoga. I would strongly suggest I would strongly suggest replacing medication and yoga bullshit with the 5 Islamic prayers daily. It's largely sufficient, I think. Class 1 recommendation, an exercise program, aerobic and or resistance, doesn't matter. It does have a net positive benefit on BP levels. Again, using risk-based thresholds for initiation of BP treatments. Basically, when we initiate blood pressure lowering medication, we should always take into consideration risk, cardiovascular risk. So when we take BP level only, we ask this simple question: does the patient have an average blood pressure superior or equal to 140/90? If yes, we start antihypertensive medications to lower BP and reduce cardiovascular risk for primary or secondary prevention. This is class 1 recommendation according to the Americans. If the patient does not have 140/90 or superior blood pressure values, we use a risk-based thresholds for initiating BP lowering treatments in adults. And how do we do that? We take into consideration other cardiovascular risk factors such as coronary heart disease, previous episodes of stroke, heart failure. If yes, we initiate antihypertensive medications to lower BP and reduce cardiovascular risk. If the average systolic blood pressure and diastolic are superior to 130/80. For secondary prevention of cardiovascular risk or cardiovascular disease. If no, we ask this question: does the patient have diabetes or chronic kidney disease? Or is the patient at increased short-term risk of cardiovascular risk, which is the 10-year prevent CVD risk score superior or equal to 7.5%? If yes, we do initiate treatment, and it's again a class 1 recommendation. I'm only going to talk about what kind of treatments to initiate and how do we do that. If no, we initiate the antihypertensive medication to, again, lower the cardiovascular mortality risk, blah, 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 after 3-6 months of lifestyle intervention attempts. So diets, managing psychosocial stressors, and acting on the previously talked about lifestyle and diet stuff like alcohol reduction, exercise, weight loss, and basically stress management. So initial medication selection for the treatment of primary hypertension, class 1 recommendation for adults initiating antihypertensive drug therapy. There are basically four classes of medications that we should use in the first line. As first line therapy, we have thiazide type diuretics. So hydrochlorothiazide is the chief molecule. Long-acting dihydropyridine, calcium channel blockers, and ACE inhibitors, or ARBs, which is anti-renin or uh, basically antagonists or blockers, renin receptor blockers. Um, uh, so these four are recommended as first-line therapy to prevent cardiovascular disease. And we should, of course, point out to the obvious here, which is that we never associate an ACE inhibitor with an ARB. The choice for of initial monotherapy versus combination drug therapy. So the Europeans recommend starting with a combo. Basically, for the Americans, there is a class 2A recommendation in stage 1 hypertension to start on first line single first line agent. They say it's reasonable. I don't know. And they titrate the dose with sequential addition of other agents is needed if the blood pressure um, is not controlled. And again, we use ACE inhibitors or ARBs or calcium channel blockers or thiazide like diuretics or thiazides. So for stage 2 hypertension, according to the Americans, a class 1 class 1 recommendation is to initiate 2 first-line agents of different classes, ideally in a single pill combination to improve adherence. So a single pill combo that has either a thiazide diuretic with a calcium channel blocker, an ACE with a thiazide, an ACE with a calcium channel blocker, it doesn't matter, is recommended in stage 2 hypertension. It must be noted that some high-risk patients with stage 1 hypertension should be initiated with a 2 first-line agent. So some people that may belong to this category and are at high risk should be treated with the same kind of mindset as stage 2 hypertension. Whatever is left, so whatever left, any stage hypertension, a class 3 harm, do not combine ACE and ARBs and or renin inhibitors, which I don't think are available yet here. So again, you must keep that in mind. Do not associate ACE inhibitors with ARBs. Antihypertension medication and adherence strategies. So to improve adherence, we use a single pill combo, class 1, once daily dosing. Again, class 1. No need to give 3 treatments and make the patient go through the agony of, I don't know, taking a pill each for 8 hours or something. Other interventions, class 2A, to improve adherence include education, coaching, reminders, aids, home BP monitoring with feedback, managing anxiety and depression. So someone who's depressed is not going to take the treatment. So again, it's very necessary to manage that. And someone with anxiety might not take the treatment. And if they do, they still have anxiety and they will not adhere to it on the long run. So goals for blood pressure in patients with hypertension. If we confirm hypertension and we have a cardiovascular risk at 10 years, superior to 7 or equal to 7.5 using prevent CVD risk score. If yes, we must have a goal of a systolic blood pressure less than 130, ideally less than 120. This is a class 1. A diastolic blood pressure less than 80 is class 1, again, as a goal. We must be of note that in older patients, these numbers are an illusion, and we must not strictly just bombard them with medication to reach these, because they are at high risk of having orthostatic hypotension and falling and fracturing their hip and ending up in a critical situation and dying because of fractured femur. So again, class 1 recommendation, we must keep that in mind, but again, it's highly adaptable to older patients. If no, we can ideally, this is class 2B, we don't strictly push for a systolic less than 130 and a diastolic less than 120, or a diastolic less than 80. So it's a little bit flexible, which is what it means in this slide. It's a class 2B recommendation. And now we talk about a very lethal combo, which is hypertension with diabetes mellitus, usually type 2. These go hand in hand. A take-home point is that a greater than 80% of adults with type 2 diabetes have hypertension. And intensive BP goals are associated with improved cardiovascular outcomes. So in patients with diabetes who they have higher, much higher cardiovascular risk, we should push for more BP, numbers. We should control their blood pressure strictly, because they tend to be patients who are undisciplined, are on multiple therapies, have weakened immune systems. They basically they come to you in the consultation room with a bag of medications, and they are sick and tired of shooting up insulin and taking their metformin and taking their heart disease medication. And so we should actually push for more adherence to therapy and more controlled BP goals. Again, in these patients, we should start antihypertensive medications for systolic superior to 130, diastolic superior to 80. The initial management, basically all first-line agents are effective. Again, the first-line agents are thiazide-type diuretics, calcium channel blockers, and either ACE inhibitors or ARBs. This is class 1. For chronic kidney disease, which also tends to be a combo with diabetes mellitus and hypertension, which both cause nephropathy. So in older patients or even younger patients with chronic kidney disease, a GFR less than 60 milliliters per minute indexed to body surface, or moderate to severe albuminuria superior to 30 milligrams per gram of creatinine, we should basically opt for ACE inhibitors or ARBs. They should be on ARBs and ACE inhibitors. So diabetic patients, chronic kidney disease, just start ACE inhibitors and ARBs. If we have mild albuminuria, which is less than 30 milligrams per gram of creatinine, ACE or ARBs can delay progression of diabetes mellitus related kidney disease. This has been proven. It's class 1. We should do it. Again, management with hypertension and obesity, metabolic syndrome, a very, very common combo. Class 2B recommendation in adults with hypertension who also have overweight or obesity and a BMI superior to 75 kilos per meter squared, increasing mimetics, GLP-1 RAs, when used for weight management, may be effective as an adjunct to lower BP. Class 2B recommendation, again, in adults with hypertension who have obesity with a BMI superior to 35. We should consider, this is very, 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 I don't think I do completely agree, but I'm not an expert. So bariatric surgery for weight loss in really severely morbidly obese patients, in combination with behavioral interventions and, of course, antihypertensive therapies, may be effective in lowering blood pressure. I'm not sure about bariatric surgery because it's very invasive and has lots of complications long term. But again, not an expert. So again, we go to another interesting theme, which is on how to prevent heart failure in adults with hypertension. Usually, heart failure in adults with hypertension comes secondary to an acute coronary event. But whatever type of heart failure we're talking about in hypertensive patients, a class 1 recommendation, we should treat systolic to less than 130 or diastolically less than 80. These two are the golden numbers. You should keep that in mind, to prevent progression of heart failure in already diagnosed people with heart failure. Diastolic, uh, systolic dysfunction, preserved ejection fraction, moderately reduced ejection fraction or reduced ejection fraction. It does not specify, and it does not really talk about any of the different classes of heart failure. It just says just lower the blood pressure, and you're gonna have a benefit on the progression of the pathology. Chronic kidney disease. If we have a GFR less than 60, again with moderate to severe albuminuria, 30 milligrams per gram of creatinine, a goal of less than 130 to decrease all-cause mortality has been proven, and is a class 1 recommendation. So basically, for renin, angiotensin, aldosterone system inhibitors, when we talk about ACE inhibitors or ARBs, but not both, it is recommended to they both recommended to decrease cardiovascular disease and delay progression of kidney disease. Again, an interesting theme here: intracerebral hemorrhage, which can be a complication. It's a complication of hypertension, especially in adults with pre-existing cerebral aneurysms. So, an acute spontaneous intracerebral hemorrhage with a systolic blood pressure in the range of 150 to 220, what we do in this kind of an emergency, highly dangerous situation, we should immediately lower blood pressure to 130 or less than 140 millimeters of mercury for at least 7 days after the intracranial hemorrhage. But we should stop medication if the systolic blood pressure is less than 130 to avoid hypoperfusion. So for a hemorrhagic stroke, we should immediately lower blood pressure values. And it's a class 2A recommendation associated with improved functional outcomes, which is what's interesting about intracerebral hemorrhage. What we care about is long-term sequelae and functional outcomes, and it has been proved, not conclusively, but with a reasonably strong strength of evidence, that lowering blood pressure in the acute phase does that. If we have blood pressure values less than that, we titrate the systolic blood pressure with medication. We do a smooth, non-labile. We avoid peaks and avoid large variability in blood pressure. And again, that has been associated with improved functional outcomes. If we have a systolic blood pressure superior to 220 millimeters of mercury, we should not be lowered. We should not be lowered below 130 to reduce adverse effects, and this is a class 3. So do not lower blood pressure in hemorrhagic strokes less than 130. Another completely different theme here, a care for adults with uncontrolled hypertension. So people who are under medication, and we try to basically figure out why they have uncontrolled hypertension. We should do a team-based care. It is recommended, which is rarely done here. Absolutely, basically not done, because most patients are, they are controlled outside a hospital setting, where we have usually teams working on diagnoses, and we have many experts from many different fields, unlike an office setting. Again, evidence-based care plan utilizing home blood pressure measurement and team-based care that is responsive to addressing adverse SDOH, which stands for social determinants of health. It is recommended. Again, this is just Americans being Americans, I think. We live in the third world, so yeah, we should keep these in mind maybe in the future. Integrated treatment model that includes accurate BP measurement, prompt treatment, patient engagement. This is very important. Usually, here patients are not engaged; they just want to take their goddamn pill and go home. And most of them just stop taking their medication. So we must implicate the patient in their own pathology, and I do recommend slightly scaring the patient uh, to improve adherence. This is my, I don't know, my recommendation. So we should review their blood pressure numbers, and we should implicate the patient in treating their own pathology. Health information technology is also is beneficial. So being in contact with the patient does help improve BP control. This is class one, by the way. It's not something um, to go by as a joke. It's not a joke. The use of electronic health records and patient registries is beneficial for screening and identifying hypertension to focus on those who need additional care. Class 2A telehealth interventions, something that is coming up very interestingly in the last few years, especially after COVID. Adults with uncontrolled hypertension placed on new or intensified medical therapy should have follow-up evaluations for medication adherence and respond to treatment and monthly intervals until control is achieved. So we should review our patients month by month, not each 3 months, or especially when we start treatment. It should be a monthly or monthly based follow-up regimen. Another theme, which is hypertension in pregnancy, um, for individuals who have hypertension and are planning to get pregnant or become pregnant, we should use labetalol and extended release nifedipine to minimize fetal risk and treat hypertension. This is very interesting because, as you know, ACE inhibitors are contraindicated in pregnancy because they are associated with fetal malformations and all sorts of really horrible complications. So labetalol, the Americans recommend labetalol and a calcium channel blocker, which is nifedipine. All the patients should be counseled about the benefits of low dose aspirin, uh, around 81 milligrams per day, to reduce the risk of preeclampsia. This is basically the work of our colleagues in gynecology. Again, this is class 3, harmful, should not be done. We should not put the patient on either atenolol, ACE inhibitors, ARBs, or direct renin inhibitors, natural peroxide, or amylase. Amylase stands for mineral corticosteroid inhibitors, or mineral corticoid receptor antagonists. This is to avoid fetal harm because usually these medications target really crucial enzymes that are implicated with fetal development. So we should not put on a pregnant woman on these ACE inhibitors, OBS, renin or amylase, natural peroxide, or atenolol. We have other options, labetalol and nifedipine. Usually here we use a central blocker, which is an alpha blocker in pregnant patients. I don't know about using nifedipine and labetalol. I've basically never seen it used, especially labetalol, because I think it's a beta blocker. It's a second line antihypertensive drug. I don't know. So pregnant individuals with a systolic blood pressure superior to 160 or diastolic superior or equal to 110, confirmed on repeat measurements within 15 minutes, we should lower the blood pressure less than those values within 30 to 60 minutes to prevent adverse events. This is a class 1 recommendation. Rapid BP lowering measurements should be taken in basically less than an hour in these patients. If people or women who are pregnant with chronic hypertension, We should treat to achieve a BP less than 140/90 to prevent maternal and perinatal morbidity and mortality. This is class 1. Preeclampsia is not very important. It's not that important, but I think it's crucial to talk about. So the diagnostic criteria for preeclampsia, according to the Americans, is either of the following: a systolic blood pressure superior to 140 and or a diastolic superior or equal to 90 on 2 occasions, 4 hours apart, after 20 weeks gestation in a woman with previously normal BP. This is the first criteria. The second one, which is like an or, it's an or statement. It's not strictly needed, but in and out of itself, it's a criteria. A systolic blood pressure to be 160 or a diastolic of 110 confirmed over 15 minutes apart. We don't need days for this. So this is the first kind of side or criteria, and it must be associated with a proteinuria with any of the following criteria: superior to or equal to 300 milligrams per 24 hours urine collection protein quantity, a protein over creatinine ratio superior or equal to 0.3, a dipstick reading of 2 plus. So so a dipstick reading of 2 plus. A dipstick reading is shimidizolin. Or other quantitative method if not available. So association of these two defines preeclampsia, or we can have other criteria, any of the following: thrombocytopenia, platelet count of less than 100, reduced kidney function, serum creatinine superior to 1.1 milligrams per deciliter, or double the baseline of creatinine, impaired liver function with double the normal transaminase range. If we have pulmonary edema, it's a very important criteria. This, if we have new onset headache, unresponsive to medication, or visual symptoms. So these other criteria can, and any of them can stand alone as a replacement to proteinuria. So, for example, if you have high blood pressure, either one of these two here, so 160, 140, 110, 90, associated with pulmonary edema. This defines preeclampsia pretty much in a pregnant woman. Impaired liver function, kidney function, or thrombocytopenia, new onset headache, responsive to medication, or visual symptoms. In the absence of proteinuria, this defines preeclampsia. So how do we manage resistant hypertension? An office BP superior to 130/80 on superior to 3 antihypertensive drugs, ACE, ARBs, calcium channel blockers, and a maximal dose of thiazide like diuretic defines resistant hypertension. Office BP less than 130/80 but requires 4 or more antihypertensives also defines resistant hypertension. So this entity here is interesting because even with controlled hypertension within the objective, if the patient takes more than 4 medications, we are in the resistant hypertension category. We have to do a workup and address potential causes. We have to exclude the entity we talked about, which is pseudo-resistance with ambulatory blood pressure measurement, medication adherence. We should check with the patient. We should remove and review and remove interfering medications. We should screen for secondary causes. Again, the criteria we've talked about: primary aldosteronism, other endocrine disorders, OSAs, obstructive sleep apnea, and renal parenchymal disease, any type of renal parenchymal disease and renal vascular disease especially. And we could look for these with I don't know, a simple clinical exam. You could find a murmur, periumbilical, classical for renal artery stenosis, and etc. I'm not going to go into details on these. This is a class 1 recommendation. So first thing, if you have resistant hypertension, check for these three things, potential causes. If we have, so now, if we have resistant hypertension, we should think about MRAs, mineralocorticoid receptor antagonists. If they are contraindicated or intolerant, if they're not contraindicated or intolerant, we should add an MRA. In adults with uncontrolled resistant hypertension, despite optimal treatment with first-line antihypertensive therapy and with an eGFR superior to 45 millimeters per minute index to body surface. So the threshold for introducing MRA is an eGFR superior or equal to 45. Of course, in the absence of other indications. So what we do if they are contraindicated, what we do is add an alternative second-line agent. That is reasonable. It's a class 2A recommendation. So amiloride, a beta blocker, an alpha blocker, a central sympatholytic drug, oxonidine, or dual endothelin receptor antagonist, which is not available here, or even a vasodilator. Can be reasonable in these patients. Another intervention, which is quite invasive, is renal denervation. I don't know if it's done here. I think it is done. I recall a case when I was an intern of a pediatrics patient with renal disease who had renal denervation. So it might be reasonable to adjunct a surgical treatment, which is this, to meds and lifestyle modifications to reduce BP in those resistant hypertensive adults at a high risk of having vascular events, not only coronary, but especially ischemic, hemorrhagic strokes, etc. All patients who have been who are being considered for RDN should be evaluated by a multidisciplinary team of expertise in resistant hypertension RDN. It should not be an individual decision. Of course, the surgeon and the cardiologist, the nephrologist, everyone should be implicated in this, and it should be a discussion among the team. For patients who are being considered for RDN, the benefits and risks of the procedure should be discussed as part of a shared decision-making process between the patient and the team, etc. This is part of the modern medicine kind of best practices. The patient should not be treated as an animal that is being taken to a butchering to a butcher shop and being denervated of their sympathetic nervous system normal wiring. They should be informed about the potential risks and benefits. Again, another important entity usually overlooked, orthostatic hypotension, especially in hypertensive patients. Some doctors imagine that we cannot have hypotension associated with hypertension. Well, it is the case. It is the case, especially orthostatic hypotension in older patients. We should monitor for it, we should test for it, and we should basically reduce the risk of falls, fractures, and other traumatic events by screening for orthostatic hypotension. This is class 1 recommendation. Class 2A, if we have a patient who is receiving intensive BP lowering therapy with asymptomatic OH, so patient with who has, when we measure the blood pressure in the in different positions, when we diagnose asymptomatic orthostatic hypertension, a treatment goal of systolic blood pressure less than 130 is reasonable due to increased cardiovascular risk and mortality benefit. So we can, in asymptomatic OH, reduce our systolic blood pressure less than 130. This is class 2A recommendation. Another class 2A recommendation is that in adults with hypertension, initiating treatment or adding medication with a goal of systolic blood pressure less than 130, assessment for symptomatic OH is reasonable to detect other chronic conditions. So we should always look for OH. And the method is pretty simple. 1 minute of standing up, you measure the blood pressure and you check how much it drops in that position. And depending on the percentage, we can say, and the symptoms, we can say if we are in the symptomatic, asymptomatic OH. And we should treat promptly and change our objective depending on the what we find clinically. So we come to a very, very interesting entity. It's a shame that it's been left to this, I think, the end of this presentation, which I hope was useful, is severe hypertension versus hypertensive emergencies. These are two different entities that every clinician, every doctor must know. It's very well. I don't think it's very well known. I think most doctors don't know how to distinguish between these two, and they don't know how to treat them. Usually, as patients do, they panic in the presence of elevated blood pressure, and it's very important to diagnose a severe hypertensive crisis versus a hypertensive emergency. And it's very simple to do. If you have a systolic blood pressure superior to 180 or a diastolic superior to 120, we check for acute organ damage. If there is, and acute organ damage can be, I don't know, visual like visual disturbances. It could be kidney dysfunction. It could be acute coronary syndrome. It could be pulmonary edema. It could be stroke or neurological symptoms. If yes, we say it's a hypertensive emergency, and we admit the patient to the ICU. We look for aortic dissection, for example, or pheochromocytoma crisis. If yes, we reduce the blood pressure less than 140. Again, for a pheochromocytoma crisis or an aortic dissection, we reduce the systolic blood pressure less than 140 in the first hour and less than 120 for the aortic dissection, so respectively. If no, it's still a hypertensive emergency. We're not in the aortic dissection or pheochromocytoma crisis. We reduce the systolic blood pressure by 25% in the first hour and to less than 160 over 100 over the next 6 hours, and to normal in the next 24 to 48 hours. So notice here that even in the presence of a hypertensive emergency outside aortic dissection and pheochromocytoma crisis, we do gradually reduce blood pressure, never abruptly. We never drop our blood pressure very fast and very rapidly, because that carries a considerable risk of having ischemic stroke or other hyperperfusion syndromes in other organs. So gradual reduction, 25% in the first hour, and we have a target of 160 for systolic and 100 to 110 for the diastolic over 6 hours, and then to normal in the next day or two. So this is a hypertensive emergency according to the American Heart Association. Very simple algorithm, very straightforward. If we're not in the we don't have a target organ damage, we call that severe hypertension. It's not an emergency. If we identify it in the emergency department, we simply don't panic. That's the first thing we should do as doctors, and as patients, we should calm the patient. We should explain the situation, that this is not very urgent, and we should evaluate the inpatient versus outpatient treatment depending on indications on other BP, other than BP alone. So if the patient is not adhering to treatment, we should ask them about their salt intake, their adherence to medication, what kind of stuff they've been taking. Maybe we should check for other interfering medications, the use of drugs, etc., etc. And we should advise the patient to basically do the opposite of whatever stupid thing they're doing to make their hypertension worse. Well, we should avoid blood pressure lowering therapy or intensified oral therapy in the acute setting. This is the cornerstone. This is very, very important. Do not lower the blood pressure either orally or intensify oral therapy in the acute setting. Okay, do not do that. It's very harmful. It's class 3. And what we do is just remove the aggravating factors and do a close follow-up in the outpatient setting in the next 4 weeks, basically within a month. So yeah, within 4 weeks we do an outpatient follow-up, and we continue checking for blood pressure values until they are within our target goals. Passing on to basically patients scheduled for surgical procedures. If we have a patient who is having high blood pressure over 180 for systolic, 110 for the diastolic, we may consider delaying the elective surgery to minimize perioperative complications. It's a class 2B indication. If no, and if the blood pressure is not superior to those two numbers, we must continue most antihypertensive medications throughout the perioperative period because it carries a lower risk of morbid mortality. It's class 2A. Special details here considering beta blockers, clonidine, and ACE inhibitors and ARBs. For beta blockers, if the patient is already on chronic beta blockers, we should continue them throughout the perioperative period, class 1. It's not harmful, we should do it. What we don't do is abruptly discontinue chronic beta blocker therapy, and it's a class 3. It's a harmful thing, should not be done. What we should not also do is start beta blocker therapy on day of surgery in beta blocker naive patients. So I don't know why the hell would anyone do that, but if somebody is going to surgery, we should not start them on beta blockers if they're not on them. Clonidine, which is an alpha blocker, a central antihypertensive drug, should not abruptly discontinued if chronically taken. Okay, it's class 3. For ACE and ARBs, we may consider a discontinuation to reduce the risk of perioperative hypotension. It's class 2B, reasonable enough if we have somebody at risk of having hypertension. Okay, so going to the evidence gaps and future directions. This is very interesting. It's our last slide, and of course I want to thank you for following with me to this part. I hope I wasn't blabbing around. I hope it was rich and informative, this presentation. So for the knowledge gaps and future directions, we need more research to improve screening and implementation and strategies for beta block control, for BP control, sorry. So we need more data on blood pressure targets and long-term benefits in younger adults, which is a population that is not studied that well. We need more studies in patients with white coat hypertension and their long-term risk, and we need more studies again on optimal management of pregnant patients, especially with complex comorbidities like valvular disease or other chronic inflammatory diseases who have complex pathologies associated with pregnancy and with hypertension, maybe diabetes again. So it's a largely multidisciplinary thing to do, and it's going to take pretty much years to reach full consensus of some of the issues in those fields. Genetics are very basic but very important in terms of hypertension. We need to understand genetic and epigenetic risk factors for hypertension. Maybe develop, I don't know, genetic markers to detect it or detect high-risk patients. Sort of like it's something analogous to the lipoprotein A, which is well, again, used in familial hypercholesterolemia in high-risk patients who have had acute coronary events or acute vascular events, strokes, etc., due to hypercholesterolemia. So, and it's gonna, of course, unlock more doors in terms of therapy, in terms of improving the specificity of certain molecules, ACE and ARBs, etc. I think this is going to be the key to treating hypertension um, effectively, or curing hypertension potentially. We need to also understand the intersection of blood pressure with race, ethnicity, and social determinants of health. From my very limited experience, I think most people with high blood pressure belong to the underprivileged lower pyramid of the social hierarchy. Yeah, when it comes to race, something comes to mind, which is a very famous study that came along, I think, 2004, on the benefits of using nitrous oxide on black people with uncontrolled hypertension. I don't know the details. I think it's very interesting, and it's simply just it's not a racist thing. It's just a variant of genetics, and people are different genetics have different responses to molecules, and we need to explore that and study it. Yeah,